Hello, good morning, good afternoon, good night. We are gonna have now Diane Carrillo, and she's gonna talk about telehealth evaluation, functional evidence-based approach. If you have any questions throughout the presentation, please feel free to write your questions in the chat. I'll be reading them throughout Diane's presentation. She will take questions during the presentation. So feel free to write your questions on the box. Okay, well, thank you, Diane. That's all yours.
Thank you. Well, it's such an honor and a pleasure to be able to be here presenting today on telehealth evaluation, functional evidence-based approach. So just wanted to start a little bit about me and my story. So, life is a story, and what does yours say? And this says about, each of us, but it also, we can relate this to each evaluation that we're doing. Each of our clients or patients is that they have a story to tell, and our job is to tell that story well. So I'm a physical therapist. I've been a therapist for 16 years. I've always primarily worked in the neuro realm, acute rehab, outpatient rehab, but have had some experience in orthopedics as well, acute care. It was about 9 years ago that I had the privilege of taking over a seating clinic when I lived in San Diego for Sharp Healthcare. And that's really where my passion for seating and positioning and mobility started to develop. And I realized that this is the direction that I really wanted to focus my career in. So I pursued getting my assistive technology, my ATP and my SMS credentials. And that was just really helped me to educate myself and to really I really wanted to be that expert. So about 3 years ago, we relocated to Tucson, Arizona, and was looking for, a good fit, a good place for me. And I really couldn't find one. So I decided to start my own private practice. And I was, just getting my practice up and going. I was a mobile therapist, so I didn't have a clinic. I worked, would go, to their homes, and here in Tucson, a lot of assisted living facilities and senior living here. So was doing that, and boom, 2020 hits with COVID, and as all, we were just struck with, what do we do? And initially my thought of telehealth was absolutely not. There was just no way I could do what I needed to do using telehealth. So, as the weeks and the months started to tick away, and realizing this wasn't going to go away anytime soon, I knew I needed to pivot, and I needed to look at some options here. It was actually on a phone call with, or it was actually a video with Julie Barth from New Motion, and she's an OT by trade, and I'm a PT, and we were like, how would we do this? And so we're kind of like acting it out, and started thinking, well, maybe there's a way. So I started doing a lot of research, because I knew I was going to have to find some tests and measures that I could use that were observable. And so started doing a lot of research and found out there really was a lot out there. So that's when, I thought, okay, I'm going to give this a try. So developed a evaluation and implemented it, and, and it was very successful. So, we were still all learning it, a lot of trial and error, and a lot of mistakes along the way, but really proved that, telehealth is effective. And I think now in the game of, almost 2 years later, we've all come to the conclusion that telehealth can be a very effective part of what we do. The problem is, how do you document that? How do you take that and turn it into documentation that is going to be, meet the requirements for funding? So about a year ago, with with complications of COVID and still really affecting my practice, I had to pivot again, and I had to make a change. And I accepted a role with Aetna as their senior clinical consultant, their wheelchair subject matter expert. And this has been a great experience. I feel very honored and privileged because I feel like I am getting to bring my expertise, my passion into this arena and, really trying to bring some good change. So that's currently what I'm doing. However, today I'm just representing myself. I'm just here as a passionate clinician and my passion for seating and mobility, just to share how you can, some ideas to effectively use telehealth and do that effectively to get the funding. So that's kind of my story of how I got here. So just today, this is a course just to address documenting with purpose, okay, using telehealth, present evidence-based tested measures, outline procedures and policies and safety and effective outcomes, and promote discussion. And as she said, feel free to put in questions along the way. I'll be making some stops because I'd rather answer them if you have them as we go. So, when I was thinking of how you create this evaluation, my first thing was just to go back to the basics. And so looking at, that specialty evaluation, what does that mean? Okay, so we know that that's the written document, and, we're documenting medical necessity for the wheelchair and its special features, the seating and positioning needs, and then there's that detailed explanation of why a particular wheelchair or accessory is necessary. And we know that, but just to the basics. And then, just looking at, how should this be reported? So, because that was the question, right? This is telehealth. I was like, how do you do this without getting your hands on the patient? And I really started to think, how was I doing things differently already? With COVID, we were social distancing. So I realized I really wasn't putting my hands on the patient. I was kind of sitting back and I was kind of watching them, what they were doing. And that was really more effective because that's our goal, is to document their function. And as therapists, we want to get in there and help them and get our hands on them. But when I realized I was really stepping back and watching what they were doing, and we're movement specialists. So, we should be able to assess function and what they're doing by what we're seeing. So that's just kind of helped me to shift and pivot to the idea of, okay, this could be done by observation. So we know that, the policy itself, and this is just kind of according to some of the Medicare guidelines, is it doesn't really give a specific format for reporting, which kind of is a problem because sometimes we're like, what do you want? But for me, we could all as therapists kind of raise our hands and say freedom, okay, so we have some freedom here to document of how we should, what we need to document. The report should be in the office or facility's usual medical record form. So, there needs to be some identifying information on that, on your documentation, which does kind of, integrate some problems with some of the forms that are out there because, they're created and but there needs to be some identifying information on the form. So that's part of their requirement. And it shouldn't be a supplier generated form. So as therapists and, as clinicians, we should be creating our own forms. We should be supplying with, documentation that's by the guidelines. And then who can perform it? We know that the LCMP, and it needs to be an OT, a PT, or a physician who has specific training and experience in rehabilitation wheelchairs. So with, just this moving forward, we should have the skills as therapists to be able to create this documentation. So if we just kind of look at, wheelchair evaluation format, and I've, with this being, the last season I've had, the last session of this conference is, there's been a consistent I've seen, in the chats and courses that I've taken is that, people are asking, well, how do I document? There's a lot of question about it, oh, is there any good forms? And there's some great forms, but when we look at what is wheelchair, it's no different than our regular documentation using kind of that SOAP note pattern. So we start with subjective, that's the information we get from our patient, right? It's, and we should be really, especially with wheelchairs, we should really be listening to them and documenting this a lot more than what we do, because it's so important of getting that subjective about what's going on with them, their functional level, and what their difficulties are. Because this can really help drive the objective. So our objective is, those are the tests and measures. This is the evaluation. So this is kind of like, I like to think of it as the evidence, okay? So we're presenting what is the evidence of their impairments. And then the assessment, is our clinical, taking those objective, impairments and stating what are their limitations, and then what's their disability, or what is the functional limitation, and what are they unable to do. So that's kind of wrapping it all up in our assessment. Now, the plan of care in a wheelchair evaluation is the LMN, is the justification, okay? So when we get to the plan of care, everything that we're asking for should be represented in that objective measures, okay? Because it's just like any other plan of care. If you were doing a plan of care for, say, a balanced patient or somebody else, you wouldn't describe all of these interventions you're going to do if you hadn't presented the evidence in the objective measures that they have a balance impairment. Okay, so you need to make sure they match, and so we should be going back and saying, okay, do I have the evidence in the objective measure to support what I'm asking for? And I can say, just from my current role, is that lacks greatly, and so we really need, to get better at that. So I think, but what if we really truly documented and it was purposeful? It was purposeful specifically for that client, okay? And so we were individual specific, okay? So, it's really hard with a lot of these pre-made forms, and that there's a lot of things on there that don't really pertain to that individual. So really, if our documentation was really individual specific. And then this valuable, and this is kind of our theme of this ISS is bringing that value. So is what you're documenting valuable? I mean, is it showing value, one, for your patient or client, and then value for the equipment that we are requesting? Okay, so kind of really bringing that value into it is going to really improve the quality of the documentation. So then I also looked at kind of, guidelines, current at the time of ISS, I'm in Arizona. So we did not have telehealth as our scope of practice. It was in the works, and, they were saying, oh, the governor's going to sign it. But when COVID hit, we did not have telehealth in our scope of practice. Of course, all the emergency orders came out, and he did sign an emergency order, and now our governor has signed, and it is part of our practice. So, kind of looking at how we would do this, and for a lot of us, we thought, oh, this is really a new thing for therapy. So kind of looking at the Federation of State Boards of Physical Therapy, went there for some guidance and found out that really they had established some guidelines in 2015. So it really wasn't a new thing. And there were some states and there were some therapists already using telehealth, prior to COVID. So what it states in their guidelines is the appropriateness should be determined on a case-by-case basis. And that's very true with wheeled mobility. It has to be, it has to be a case-by-case because it's not always appropriate. So we should use their therapist judgment. So, definitely our judgment on if it's best, client preference. So maybe it's, that's what they prefer. It could be more, there's a number of reasons why it could be more convenient for them. Here in Tucson, there's a lot of remote areas that we cover, you know, what are couple hours away. And so, you know, telehealth really makes it much more accessible. They don't have to come into a clinic or come to into, you know, drive several hours. So, you know, whatever their preference. So that should play a big role is what their preference is. Is technology available? So, you know, a lot of people don't have the technology, and kind of the model that, you know, we've kind of seen with real mobility is a lot of times the ATP is present and they're bringing the technology. So that makes it, you know, it takes care of that. But some elderly, they don't have that technology and that ability, although I think some have had to learn technology to, you know, because telehealth has been used so much with even doctor's visits, you know, looking at risk and benefits, professional standards of care. So our standards of care should not change, you know, I mean, because it's a telehealth. Verification of identity. So you're making sure you're still doing those identifications with the patient. Informed consent. We need to, you know, get that, that consent that they're consenting to a telehealth visit. Develop therapist-client relationships. And so this could really be a good way, you know, to develop it. And we'll kind of see that along the way here. You want to follow your state and jurisdiction practice. So know your practice acts in your state for your discipline. Therapists own all responsibility and professionally and legally. So that is really huge, to really take that responsibility and that role that, you know, you are responsible for what is going on in that telehealth visit. So, you know, just making sure those safety measures are put into place, you know, use HIPAA compliant platforms. We've heard a lot from different, you know, from different courses already, you know, in this, that, you know, just the importance of using that HIPAA, and there's so many available to us. And then establish written policies and procedures. So those are just some of the guidelines put out by the Federation of State Boards of Physical Therapy. So just looking at policies and procedures. And so these are just kind of some of the ones that I implemented myself. And I know there's a lot of guidance on, you know, in RESNA and just different areas of that you can go, you know, to help establish policies, but just screening for each referral. So, you know, prior to scheduling that evaluation, is it appropriate just by kind of screening the referral? And then using a telehealth visit to gather the subjective information and get acquainted. Caregiver and family member must be present. So especially for that evaluation portion where you're going to be wanting to see their function, you know, that's critical that either their caregiver, whoever's providing that care, or whoever's their normal, you know, who's there on a daily basis, should be present for the evaluation. And then not relying on the ATP to perform tests and measures and transfers. And, you know, they are a great assistant. And I think if we're developing those good rapport and those good relationships, you know, there's them assisting you a little. And just kind of one example is, you know, I would have them, can you put the cone 10 feet away from them so I can do a tug? I mean, that's different than help me transfer them, you know, oh, you know, and you know, I saw a little bit of people like having them do muscle testing. That's not appropriate, and it's not in their scope. So don't put that on the ATP. You know, that's our responsibility as therapists, is to get that information in a safe and going back to those standards of practice. And then coordinate with the ATP prior, you know, and I hope, you know, hopefully you've already developed those relationships, but, you know, develop those relationships with the ATP. You know, you really learn your flow and what's to expect both ways. Explain expectations to the patient. So really explaining to them ahead of time, this is, you know, what I'm going to expect of you. This is what I need. And then obtaining the consent and the verification, like we said, use HIPAA compliant platform, and then document location of the patient and the therapist and who is present. So really important in your documentation that you're documenting that, and that kind of goes kind of for your safety, and, you know, so that it's documented well. So kind of looking at treatment options and kind of plans is telehealth may be appropriate for just one or all of these options. It should be based on therapist judgment or the patient's preference. And then you can plan, should maximize the outcomes along the way. And also it can increase your billable units, which is important for us seating therapists, because trying to get billable units is really important to make it sustainable. So we can start with, visit one could be that pre-screen, that subjective, getting that subjective information, then deciding like, I think we're good with moving forward with the telehealth evaluation portion. And then if that is done, telehealth, the equipment trials with the ATP, that could be done telehealth, and then you could be documenting, your plan of care during that visit, delivery, and then those follow-ups. So, it's kind of like this continuous cycle, and a telehealth really could be for one or all of these, and so at any point in the cycle, an in-person might be more appropriate, and that's your clinical judgment. All right, so I just want to stop. Is there any questions that currently that we'd like to address, or Yana?
Sorry, yes, I was having computer problems. There is a comment. Some HPs who work for CRT providers are licensed OTs and PTs. They are capable in assisting with the physical evaluation.
Yeah, and I think that's yeah, and I think that I'm not sure how that kind of crosses over. So I would agree with you that they have that license, and that would be a great scenario. So I would think that would be perfectly fine. So I thank you for that comment. That is a great aspect of it. Okay, so moving forward, so just looking at that pre-screen visit, okay, so this is where it's a great opportunity to get all of that subjective information into your evaluation. So, and I typed as during my evaluation, and I learned from some great, experts early on is that, you need to be documenting while you're evaluating. If you're saving your documentation for after any type of wheelchair evaluation component, you're going to be just spending a lot of time. So that was one practice that I really put it into play, and it's very effective. So using this first pre-screen, kind of this subjective, there are some states, and I know Arizona is one of them, that telephone is acceptable. And so, this could be a telephone call. It just depends on your state and what your practice act says. And then also we have the, insurance issue if they'll cover that, but some instances a telephone is feasible for this portion. So we're getting that history, the mobility limitations, documenting their home, living environment, caregiver, and this detailed information is really important. So we're really setting that stage. We're starting to tell their story, setting their stage, and really giving some good information on their home environment, who's their caregiver, who's assisting them, how much. When it's just vague information here, we're kind of not really telling their story well. So we want to really get good information here and be documenting it in detail about their MRADLs. This is all based around their activity, their MRADLs and their ability to perform them. So the more detailed we can be, the better. And then getting their current goals and their, what device they're using, why that's not working. So the advantage of this would be, one, to build that relationship and the rapport. Okay, so also to determine appropriateness. So with this, you may make the decision, it's telehealth isn't really going to work. I need to see you in person for your evaluation, or, maybe the other, that, yeah, I think we can do this effectively. And then, it'll help you establish your plan, just through this pre-screen. And, you've had some billable units here. So moving towards the evaluation, the objective measures. So kind of going back to when I was trying to put this all together, this is right after ISS 2020, and I had taken a postural course with Tamara and Leanne. And I remember in that course just really thinking, man, how could I implement this into my practice and my evaluations? Like, it's so functional and it's really gives so much information. So I kind of, had that in mind when I was thinking, how would I create a telehealth evaluation? So I kind of thought, okay, we want to see them in supine, we want to see them in sitting, and we want to see them in standing, just as we do with, all evaluations. So that's kind of how I designed my evaluation to flow. So their level of function will determine where you start and where you stop. Okay, so we may want to see everybody, in all three positions, which is ideal. But for telehealth, because we're thinking of safety and functionality and your ability to observe them, is we might have to pick and choose what's the best for this particular individual. But we know we want them to be observable, we want it to be functional, and we want it to, to be evidence-based, okay, because we want it to be reliable. So starting with just supine, and so these are kind of our lower level patients. And back to kind of describing and telling the patient, what you're expecting, is if I felt like I definitely wanted to see the patient, supine in bed, or I would let them know, we're going to start the evaluation in bed. So if, say, like, especially if they're a Hoyer transfer or a difficult transfer, I just kind of let them know up front that, this is where we're going to start. So maybe just when, we start the evaluation, just, be there. So we don't have to do that extra transfer. So you want to, document, are they demonstrating functional lying posture, without limitations and impairment? So, it could be a yes or no, or, and if no, then describe, what you're seeing, give some details, is it contractures, tone influence, dystonias, reflexes, could go on and on and on. But, what are you seeing in supine? And then looking at those functional transitional movements. So those are really important to document because it kind of shows function and their need for assistance or dependence. So just looking at that bed mobility is important information. And then their transfers. And so what's really important in a transfer in any evaluation is we're documenting the method, okay, the device, level of assist, and who assists. Okay, what's commonly documented with transfers is a checkbox assisted. Well, that doesn't really tell any information. Okay, so that is a very important functional movement that needs to be well documented and give as much information as you can. Okay, so just important to really include that in all levels. Oh, sorry, I went backwards. All right, then the trunk control test. Now, this is an assessment that I found when I was researching. This is validated for stroke, okay? It scores 0 to 25 for each one, okay? So, and this is something that's completely observable because this is, you're seeing if they can do it or not, okay? So you can rolling to their weak side, rolling to their strong side, balance in sitting position, and sitting up from lying down. Okay, so you're just going to score them a 0, 12, or 25. 0 is unable to perform without assistance, so they can do it completely independent. 12 is able to perform that abnormal style, so maybe they show some, some tone or just whatever dysfunctional movement. and then able to complete normal. Now, for the sitting balance, I know if they are if they require support, even arm support, then that's gonna be a 12. So each of these tests and measures that I have in here at the end, and I've provided my PowerPoint in the uploaded in the documents, is there's going to be links that you can click on them and you can go to and get the description and more in how to perform it and more about it. We don't have time to go through in detail, but what here is the score of less than 40 indicates a non-ambulator. Okay, so it's a validated test and measure we can use to show, especially those low level, that they are non-functional ambulator.
I'm sorry, Diane, we have a question in the chat.
Okay.
In supine, do you document if they are placeable in neutral? For example, posture and postural ability test.
I mean, you can, if that's all, if all you're going to get is the, all you're going to be able to do is supine. Hopefully, you're at least able to get them up on the bed, up sitting at the edge of the bed. And so that's where you would want to be documenting their sitting, posture. But definitely, and just like in any mat eval, we can document what they're, in supine, their posturing, what they're, what we're seeing, as opposed to sitting. So, if we should be trying to get as much information as we can. So definitely, if you want to document those postures in supine. All right, so strength assessment. So, that's probably one of the big concerns was how are we going to address strength, and so, I mean, I know any of us here listening here today knows that manual muscle testing does not correlate to anything wheel mobility. And as far as I'm concerned, I would love just to see it eliminated, but fortunately, a lot of payers just live and breathe on muscle testing, which is unfortunate. So, how can we assess strength? So I found 2 assessments, that we can use in supine. One is bridging. Bridging is a very common testing measure we use in therapy all the time. Are they able to bridge? And we use it, as pre and post assessments all the time for, can they bridge? Oh, we do some intervention. Oh, now they can bridge because whatever intervention we've done. So, just looking at, are they able to bridge? Can they lift their butt? Do they have good control? So kind of grading that. I did create these grades. This isn't, one that's, validated, but just, using the bridge as, and documenting, and I just used a good, fair, and poor. The good would be able to lift their hips in full extension, maintain knees in neutral, good control on descent. So showing good pelvic control, as opposed to like poor is unable to lift their hips, demonstrate poor hip strength and motor control. So what can we glean with this? If they can't bridge, they can't lift their hips up, then we could probably correlate that to weight shifting, if the supine's all we're going to get. Active straight leg raise. So this is actually a pelvic lumbar stability control test that is used. So you're just going to ask them to lift their leg up, and these are actual scores of this test. 0 is not difficult at all the way to 5 is unable. Then you do each side, come up with a score, and you can, if they get a score of 8, then that can lead, you can say that, that leads to hip and leg weakness. So you can correlate that with their leg strength. Looking at active range of motion in supine, I mean, I don't know how much this is truly going to correlate to wheeled mobility, but other than just limitations of being able to, reach overhead, bending their arms and their elbows, and, knee to chest, and then hip abduction and adduction. So, I mean, just if they don't have that range of motion, those are kind of, you're starting to kind of relate those to positioning. So considerations for all documentation is, we know we want to correlate it all to their ability to perform their MRADLs. Can they stand, ambulate, use a manual wheelchair, up through the progression. So ruling out, and showing that they have that mobility limitation. Relationship to their need for power seating features. So, we want to correlate everything we're testing to that, as well as the posturing and the positioning components that we may be requesting. So moving on to sitting, and as I stated, you could be going through all of these, or you could just be starting and sitting, or whatever is best for that client, and you've made, that decision of what you're going to need to be able to see to document for funding. And so, you don't have to do all of these. You may choose to do, something in supine, something in sitting, something, so this is just hopefully to give you kind of a bucket of tools that you can use to coordinate what you're going to do specific for that individual. So if we haven't already done so in supine, we're going to look at their sitting at the edge of the bed, document their ability to maintain that balance. You can document, do they require support, support from their caregiver, or do they just need their upper extremities, or no, they can't, maintain that control, or just unable, they're completely dependent. So just as we would, in person, looking at edema, and, this is a good thing to be looking at. Let's say you've taken them from supine and now they're, you're sitting, maybe even see what they do over time, because that kind of can correlate to, obviously, that dependent position, they get worse. I'll say probably one of the biggest things I see missing from objective measures is edema. But yet we get to the LMN and you're requesting power elevating leg rest to control their edema. So make sure you're addressing it in the objective measures. Vision, this one can kind of be tricky. Be creative. I have, been able to kind of do some tracking and scanning telehealth, but sometimes we can just use their history and any kind of subjective reports on their vision, just to make sure they're going to be safe for, especially if it's power mobility. Looking at active range of motion and sitting, raising their arms over their head, hands behind their head, touching their opposite shoulders, hands back behind their lumbar spine, knees to chest, knee, just looking at that active range of motion. And these are all kind of functional things that, we observe all the time. So, just, I mean, sometimes, if you feel like, if you've done, a lot of us therapists, we've done a range of motion for so long, and you want to guess at a measurement, which, like, shoulder flexion is pretty easy to kind of give a range in there, but just kind of that active range of motion, once again, correlating it to their function. So postural control and positioning, and this was probably for all of us the biggie, right? Like, oh, am I going to do a MAT eval? There's no way I could do this via telehealth. And it's not in person, and there will be some that absolutely we need to see in person. However, I found that it was pretty effective to see, what their posture's doing, and in sitting. So it's not ideal, but it can be effective. We want to just look at all the things we normally do, supported and unsupported. And if they're able to sit unsupported, you want to see, what does their posture do? Do they have flexibility towards midline, the ability to self-correct, tendency towards those destructive patterns? So, do they fall into those destructive patterns? Tone influence, what are you seeing tone-wise? Are you seeing a lot of spasticity or tone that's affecting it? And then able to weight shift. And these are all things, we can effectively do by observation. And then do they require an in-person visit? So this definitely is one of those that for many of us and many of our clients will, require that postural control, that in person. As far as funding, if we're just wanting to get the documentation done, I think it can, effectively be done. Like I said, one of the areas that is definitely a in-person for many of our clients that we might see. So functional transitional movements. Okay, so really moving towards more of that functional approach, reaching activities. They're in the home, most likely, if you're doing a telehealth, it's a great opportunity to watch their ADLs, watch them go into the bathroom, trying to reach for objects, watching them go into the kitchen. So really a great way to look at their function because they're in their home, which are, things we're not going to be able to see if they're in clinic. Sit to stand, use of upper extremities, are they unsafe, are they unable? So, being able to document that, and so especially, even that relating that to their functional activities. Transfers, once again, method, device, level of assist, and who's doing it. And so really important that we are documenting transfers thoroughly. And then mobility, if we're at the sitting stage, how are they currently, are they already wheelchair dependent? Do they have a wheelchair? How are they getting around? How are they getting room to room? And, and maybe doing some time tests. I want you to wheel in to the bathroom and time them. How long does that take them? So that we can really use some real life functional activities and document by, doing time tests or just giving an observation description of what you're seeing.
Diane, I'm sorry.
Okay.
We have another question.
Okay.
Do you use a particular scale to measure edema or just describe it?
Well, and it's sometimes, we're not there, we can't, push the edema and, see, but I think, it's easily to document they have pitting edema. It's, pretty obvious. You can, I would say, like if there are caregivers there and, if you felt like necessary, you could, like, can you just like push on their ankle, let me see. But, I think edema scale wise, it's hard, to use that measure because we're not there and we can't, give it a grade. But, pitting edema, just what you're just describing what you're seeing. The discolorization, so it is, we want to be careful because we want to be evidence-based of using test and measures that do require our hands-on skill. So functional strength in sitting. So sitting knee extension. So this is actually a test that's a movement control test. And so we're looking at actually what it's looking at in the published test is pelvic control. So what you're going to do is you're going to ask them to straighten their leg out and try to maintain your control. So if most of our clients are not going to be able to maintain that pelvic control or, even, lift their leg. So, use it appropriately, but it is a validated test for strength and function. And, something that we could kind of correlate to their pelvic control. So when we're talking about, their positioning and things that we need to request, showing that they have pelvic instability. The 5 times sit to stand, probably one of mostly used test and measures in all. What I see kind of across the board is the 5 times sit to stand. So very effective if they're able to do it safely, so that once again, you want their caregiver there or whatever their level of function is. And we know that the cutoff is, greater than 16 seconds, indicates an impairment. And this can indicate weakness. If they have to use their arm, technically, according to the guidelines of the test, it's a 0. They need to be able to stand up without their arms, but we can document appropriately. So if, say, they, did use their arms, then you want to document that they used their arms and how difficult that was. So, a great test. The chair push-up test. The chair push-up test is actually a test that was designed for lateral posterior elbow instability test. But in our world, we call it, can they do a pressure relief? So, are they able to perform that wheelchair push-up? Are they able to push up, fully extend and hold? And unable, or they're unable to fully extend their elbows, or they're just unable to perform it. And for here you can document pain, you can weakness, that didn't have the range of motion. So whatever, just documenting what you're seeing as well, along with the test. The modified functional reach. So this was adopted for individuals who are unable to stand. So perfect for a wheelchair. And then reaching, less than 7 inches. This can be tricky with telehealth because you think, okay, you don't have the ruler alongside the wall like we know we're used to having in clinic, but think outside the box, and just, you can have, reaching for an object, or, if you're, on a roll with your ATP and, maybe they have a ruler there, or, or just, a lot of these things we have to think outside the box and kind of improvise.
I'm
Yep.
sorry. We have another question.
Okay.
How long do you have them hold the chair push-up? 10 seconds?
Well, that's going to depend. If we're actually testing, for pressure reliefs, what, here we're on that slide, it's 30 seconds is for an effective pressure relief, so, but, you could, that's something you could do, or you could time it, and see if they can hold it that long. But for that test, it's not, there's not any specific time, because they're just testing for the function of the elbow. So that the test itself doesn't state any, times but we could use that, because that's important for our information, is finding that time. But the test itself doesn't validate any time period.
I have another
Yep.
question. Chair push-up test. Is that a lot on the shoulders? Is there something that is less strenuous on the shoulders?
As far as a chair push-up, I don't know. I didn't find anything. And so, that where, you would just document. You could even say, attempted, but unable because of shoulder limitations, shoulder pain. But, we all know, any pressure relief is a strain on the shoulder. So it's, a chair push-up, there's really no way to decrease that shoulder involvement, because that's what's required. And that's why it's so difficult for so many of our clients to do that effective pressure relief, is because they have shoulder impairments. So, looking at sensation and skin pressure relief, really no different than, what we would do in person. The only difference is sensation. Well, obviously we can't test, we can't do any, pin pricks, or, test their, feeling sensation. So it's a lot about self-report. We can use diagnosis related. So say they have, neuropathy reported, and that's, a documented comorbidity, or, like a spinal cord injury where, they have, no sensation below a certain level, a hemiplegic where, they have impaired sensation, but then just documenting why, when a lot of times we see sensation impaired. Well, impaired how, why, what, like I say, we're telling their story. So we want to give as much information in detail as possible about, each impairment. Skin, the same thing, current, same thing. We're going to document, they have current history, a history, the location, the stage, how long ago it was. And then, for telehealth, I think it's really important that we're documenting, is this just self-reported? Are they telling you, oh, yeah, I had a history, or I've had a pressure sore, or is it something that we gleaned from the medical record itself? So I think really important that we're establishing that. And like I said, we're trying to be valid, we're trying to be evidence-based. So if it's, and if, they're reporting and you're really, and you're going to be needing, a pressure relief cushion, and you're going to be wanting, tilt, recline, it's, probably a good idea to investigate that and find out, especially if it's not in the MD face-to-face note, they don't have that ICD-10 code and it's not reported there, then, we should be trying to find that information. So they're reported and they're represented well.
I have another question. I'm sorry. Would a forward trunk lean or sideways trunk lean be just as effective for pressure relief? I only work with spinal cord injury patients.
I think the research, shows it can be if they're truly offloading, but that's the trick with the side lean or the forward lean. And one, can they return back to midline? So can they lean forward and then, and then return back to midline, and, and can they do this 4 times an hour, 10 hours a day? So it's really looking at, documenting that, what they can do, and can they do that effectively all day long? So, I think research shows that, it can be effective, but are they doing it as frequently as they can? And what else is that, is it compromising their posture, their positioning? When they do that, do they fall out of, their supports and they have to be repositioned? So really looking at all of those things, just as we would in person. All right, so say we get to standing. So first question is, do they demonstrate the ability to stand for assessment? Yes, proceed forward. Yes, with assistance, make sure you have adequate support. They feel comfortable and you feel comfortable to proceed, okay? Safety, safety, safety. And you wanna protect, like we said in the beginning, you're responsible, okay? So regardless if you're in your office and they're at home, they have a fall, you're liable. So we want safety, safety, safety. So one, what's their prior level of function? Are they an independent and home? And maybe we're assessing for just a group 2. This actually could be kind of a good place to start, So safety, safety, safety. So ask yourself the question, are they able to safely stand for the assessment? And if not, then, we're kind of done getting test and measures, So just be careful proceeding to standing. If they are, we can look at active range of motion, reaching over their head, trunk rotation, reaching towards their toes, side bending, hip flexion. These are all functional activities, functional range of motions that we need to be able to perform in standing. So, just documenting if they're within functional limits, limited, unable, whatever, however you want to document to justify, to quantify it, but just looking at those functional range of motions. You can document, they're able to do it, but they have to hold on to the walker with one hand, and, so just be safe. Balance, fall risk, endurance, and strength. So we want to get fall history, kind of the norm is, how many falls you've had in the last 6 months, you want to get frequency, and what activity were they doing when they had the fall. 30-second sit to stand. So now this is different than the 5-time sit to stand. And this test was developed because of the ceiling effect of the 5-time sit to stand. So this is actually more for that higher level functioning client or patient, whereas the 5-time can be more that lower level. So don't have to use both. You could use one or the other, or you could use both. But so it's a different test, because this one you're just timing them for 30 seconds. How many times can they sit to stand? Once again, the test, we are supposed to be able to, not use your hands, but if they do, then you just document that. They could do it, but they had to use their hands. So it just kind of adds to your evidence of their impairment and their ability to perform that. TUG, probably, again, one of the most common, what we see, great functional test. Use it as much as you can. It's a great test. And we know less than 14 seconds, or greater than, I have that backwards. It should be greater than 14 seconds as an impairment. So great test. Single leg stands, something we've used clinically, or I have, myself, and kind of always the known thing. If you can't stand for 5 seconds safely, you probably need an assisted device. But looking at that single leg stands, kind of just that balance assessment. And can they do that without holding on? Strength assessment, kind of that. So modified Trendelenburg test is a great one you can use, and that's just lifting their leg up. Does that pelvis drop? They have hip weakness. So very validated for showing hip weakness, something we can do by observation. And a positive sign is just when that pelvis drops. So easy, quick and easy test. The calf raise senior test, this is a new one that I actually found when I was researching. It's fairly new. They can hold on to the wall, they can hold on to something. We're looking at kind of ankle strength, and they get to stand on both legs for this one. So it's not a unilateral like the regular calf manual muscle testing. And you're timing them for 30 seconds on this one. And then you're just counting how many they can do. So less than 18 is what the cutoff with the research showed that they indicate impairment. So a big one, a good test and measure to have, especially for, those like group 2 chairs. Maybe we're trying to justify just to have a validated strength test, because calf weakness, leads to falls and all those things that we know. So a good,
I just want to let you know you have 5 minutes.
Okay. Wow, we're going fast. Okay, so good. Well, we're almost done here. So, and then, in the end, looking at all that mobility transfers, once again, method, device, assistance, who's performing it, gait. At this point, if they are ambulatory, once again, use caution. Do you feel, safe, comfortable with them? There's a lot of ways we can, show that they have gait impairments, probably, hopefully with the test and measures we've been doing and we've shown, we can show that they have weakness, they have balance issues. So that's just one to use cautiously with telehealth. Wheelchair skills, like I said earlier, you can say, will into the bathroom, time them, or, whatever it is, what's limiting. Is it shoulder pain? Is it shortness of breath? Is it fatigue? On and on and on. So just definitely, making sure we're ruling out that manual, ruling out the scooter for going to power, and then power. And then equipment trials are so important. And I think, and so I think a lot of times in clinic, depending on your clinic and your setup, these can be, very difficult, or they just don't happen. Somebody say, oh, the ATP is going to go out and trial it. This is a great way for us to be in on that, to see the trials in their home, and we can just use you could be a whole nother visit looking at those trials, and you document it as the therapist that you saw the trial and they were able to use the equipment. So great option for another telehealth. So just real quick, I kind of just throw this in the end, is just use outcome measure. Questionnaires are great. It's just another piece of evidence-based information to put into your evaluation. These are just some of the ones I've seen along the way, kind of researched some of them and kind of thought, I like that. So won't go into detail on those, but they're there for you to review. But just use outcome measure questionnaires. It's a great piece of evidence to add to your evaluation.
We have one question. Sorry, we have one question. Have you successfully completed pediatric wheelchair evals through telehealth, especially for kids GMFC at 3 to 5?
You know, I was not a pediatric seating therapist, so I have not done pediatrics. So, you know, that's a tough population for this. So probably, you know, one that you would integrate more of the telehealth into other aspects of maybe getting that history or follow-ups or something else. So I can't answer that. I was not a pediatric therapist, but I could imagine that the involvement and the difficulty of trying to get tests and measures done would be fairly difficult in the pediatric population. So just in conclusion, I believe that practice, time, and evidence will show that telehealth is an effective and valuable way to meet the needs for wheelchair service delivery. Be purposeful, be specific, and show value in your documentation. So at the end of there's those all the links. So you should be able to just click on the link out of the PowerPoint and it'll take you to any of those tests and measures that I went over, and it, you know, will give you the descriptions and how to perform it. So, and then these are my references. So, okay, any further questions? You know, we're out of time.
This was wonderful. Thank you so much. And just to let everybody know that this is going to be available for like 1 year. So if you want to access, go back and watch again, and the resources are going to be there. And the handout was posted as a conference in the lecture. So thank you. There are comments. There was an excellent presentation, my favorite of the conference. That session code, okay. Oh, I gave the, so I have a session code FPMGFJ. And I post on the chat, it was somebody commented the session code doesn't show as an option on the survey. Hold on, let me just double check. I'm so sorry. I'll double check that. FPM GFJ. So that's the code that I have for this session. It is again FPM GFJ. If anybody has any trouble with that code, I guess reach out to Carl or some of the organizers, and they probably will give you the correct code, but that's the code that I have. Thank you.
Thank you, everybody. Okay, thanks, Anna.
Thank you, Diane. This was wonderful.
Okay, have a great day.
Thank you, you too. Bye. There's a lot of comments, Diane, just saying like, great job. They